Um, Thank you, Benedetto. Indeed, I'm coming from a country, Japan, which has been recently hit by major disasters. And it's a pleasure for me to be here in this meeting with you, talking about mental health issues. As you may know, Japan is the only country in the world that faced 2 nuclear bombing. And as an irony of history, they are now facing the trauma of another nuclear incident, which consequences we'll still have to investigate in the future. I will go back to Japan at the end of my presentation. As was mentioned by Benedetto, I work for WHO, which is the World Health Organization, in a center in Japan which deals mainly with urbanization and health and the linkages with health inequities. This center is having a global mandate. We are working globally attached to the headquarters in Geneva, and we are not a country office, neither attached to a regional office. So our research is really conducted at a global level, and our lessons should be applicable at the global level as well. In my presentation, I will focus mainly on the urban dimension of the problematic we are discussing today. Specifically, I will address 3 axes which correspond to the activities in which my center's research is focused. The first one is identifying social determinants and conditions that impact on health in the urban context. The second one is to develop tools to assess and respond to urban health inequities. And the third one, is to help identify measures and interventions that address these inequities and health outcomes. First, let me emphasize a very important point. Whichever political model we will find conclusively positive for mental health and for the topics we've been discussing over these 3 days, we now know, and this has been known for a long time, but we have even better and new evidence that mental health is closely related to social and health inequities in cities. This is very important. Whichever political model we will follow to address mental health, this is a key element that we have to bear in mind. And I would like to give 2 examples of this relationship and also put the spotlight on one specific tool that allows us to unmask these inequities. This is Preston. This is a city in the UK, and that we studied extensively over the last 3 years, and we published the conclusion of this study in a joint global report with another UN agency, which is called UN Habitat. And this report is named Hidden Cities, Unmasking and Uncovering Urban Health Inequities. This report is available for free online, and also I brought today some executive summaries that are available on the table outside. One of the examples we studied in this report was Preston, as I mentioned, in the UK. This is a growing city of 132,000 people, and there's a big university there. There's also the home of the British Aerospace Agency. Within Preston, very importantly, life expectancy varies dramatically between the largely deprived communities and the more affluent ones. Men in affluent areas live 14 years longer than those in deprived areas, 14 years. For women, life expectancy varies 10 years between wards. That's a huge difference. When we use the data extracted from the National Health System to map out income inequalities and crime and disorder inequalities, we found that there was a strong correlation between income inequalities and crime and disorder, which are linked to mental ill health. Now, the good news is that local leaders, local politicians, use this information to better tailor interventions and services to communities with the greatest need. And I'll go back to that at the end of my presentation. Let me give you another example. This one is provided by the London Health Observatory. And yes, sorry, it's another example from the UK. They have good data there, and we studied extensively this information. In their study of suicide that they conducted in 2008, if I recall clearly, they realized that despite an overall decrease in suicide rates in London, there are considerable inequalities in health, in mental health, ill health, linked to socioeconomic status. In London, 16 to 18% of adults experience mental health problems in a given week. As you can see from this graph, the prevalence of mental health problems is in most deprived parts of London, 20%, is twice as high as in least deprived areas, twice as high. It is also more common among people in routine and manual occupation than people in managerial and professional occupation. The National Health System also concluded that the data it collected, that mental health admissions rates among London's black ethnic populations was 2.6 times higher than the general population rate in England. And this resonates clearly with the presentation given by Sashidaran on Monday. This graph. Now, all this information which help map out these inequities is critical to lead policy making. And it is made possible only because local governments are made available data on the health of their population, which allows precise analysis of health inequities. One such tool among many that has been developed by the World Health Organization is called the Urban HEART. So HEART stands for Health Equity Assessment and Response Tool. This tool, which also have brought some brochures, gives policymakers and key stakeholders at national and local levels a guide to assess and respond to urban health inequities. In Japan, we use this tool to map out inequities in mental health between and within a set of selected countries. So one of the features of this tool is a matrix that helps to identify and map out key indicators and to evaluate their performance. The objective of the study we conducted in 2009 in Japan was to measure indicators deemed key in mental health-related issues in a population of 4 cities in Japan: Nagasaki, Okayama, Sano, and Isogo. In Japan, the number of patients with mental disorders is growing. And it's not growing only because of the consequences of the recent disaster, but it's been growing constantly over the last 15 years. For instance, the number of patients with mood disorders has increased by nearly 500,000 between 1996 and 2005. We completed several studies on mental disorders and social development in Japan. Our main data source for analysis was the World Mental Health Japan survey, which is a WHO survey conducted from 2002 and 2006. In this table, we group the main factors considered to influence mental health in general and specifically in Japan. So as you can see, the performance of each indicator is measured against national average. For example, if I take living alone, for Nagasaki, Okayama, and Isogo, the first line at the top, we can see that the performance is worse than the national average. If it's a yellow sign, it means that the performance is up to 25% better than the average, national average. And if it's green, it means that it's better than the national average. So this is a very important tool for policymakers to enable the tailoring of political action and to orient political action where the need is required. So the need to understand precisely where the situation is appealing and important is key. Now, how do we respond to the challenges that mental health poses in our cities? There are various policy choices that may directly and indirectly affect mental health and health inequities. Any public policy at the national, regional, or local level will have may have an impact on mental health. If a city government chooses to tackle mental health through the mental health care system, we, WHO, recommend that mental health care should be available at the community level for anyone who may need it. I will not develop too much here because there is ample literature and details on the reasons, solutions, and consequences of this choice. And Benedetto is one of the artisans of these recommendations in our organization. So you can have more information on by accessing the different documents of WHO. But this is one approach.